pleasure to introduce our last but not least speaker, Joe Friedman, a current third-year medical student at the David Griffin School of Medicine and the Medical Scientist Training Program. He just completed a PhD in social medicine at UCLA, so Dr. Friedman. His research is epidemiological and ethnographic in nature, focusing on difficult social problems like addiction, overdose, and violence. He does work in LA and on the US-Mexico border related to harm reduction, migration, and substance use. Let's welcome him.
Hi, everyone. Hi, everyone. Thank you. This is a story about pain. Working in medicine, pain is all around us. Broken bones, torn flesh, infected wounds, cancer eroding through skin, kidney stones, strangled organs, and dying bodies. These things create pain. But we are at a unique time in medicine where the authenticity of our patients' pain is increasingly being called into question. But pain lumbers along, oblivious to our opinions of it, because pain is part of the human condition. Pain marks the privilege of having survived long enough to feel it. Pain reminds us that we are alive. But pain is invisible. Pain exists only in the neurons and the souls of the people who experience it, and ever more often, we are led to doubt our patients when they tell us that their pain is still there. New state surveillance mechanisms carefully track for statistical signs that the purported pain of our patients may not be legitimate. Stories of busted doctors circulate. Lawsuits against opioid pharma fill the news, and we feel pressure. Polished PowerPoint slides and administrators and algorithms and guidelines and insurance companies and peer-to-peers and all of the endless soft power invisible hands that shape the contours of clinical care tell us that maybe we should be prescribing just a little bit less, and we feel doubt. But in the midst of these pushes and pulls, some patients receive more opioids when they tell us that they still feel pain, and others do not. Here are two stories for you about pain, two patients, one whose pain was not believed, and one whose pain was. The first is a Spanish-speaking man who I will call Jose, although that is not his real name, who was admitted to the perfectly average county hospital. He is writhing in pain, vomiting on the floor of the ER, and a diagnosis is made of acute pancreatitis. Although my team is frantic, dealing with a dizzying array of sickness and suffering, I am the medical student, so I have plenty of time to speak with Jose. He tells me about growing up in a Mexican city that I have been to, and we connect about this shared experience and swap stories. He tells me about the loneliness of moving to this country without his family, of not being able to go home, but he tells me of the pride he feels about his labor and the money that he earns that he can send back to his family. As we tick through the standard medical interview questions, he tells me that he knows he needs to cut down on his drinking. That six-pack every day after work helps him forget his loneliness, but it is inflaming his organs, and he knows that it's not good for his health. The term alcohol use disorder is slapped onto the one line that represents the summation of his condition. And Jose is in pain. He receives a small dose of short-acting opioids every 4 hours for this pain, a baby dose, as my senior resident called it. When I run a milligrams of morphine equivalent calculator on the CDC website, it tells me that Jose is receiving a total value of 10 units per day. And at first, these units are enough to keep the pain at bay, but by the end of each 4-hour window, the writhing returns. Our conversation becomes punctuated with grunts of pain. Jose requests more opioids. The nurse checks the computer, pages the intern sees the patient. An interpreter is called. He waits for 5 minutes for the interpreter to connect. Their conversation is punctuated by intermittent, frustrated pauses as the Wi-Fi comes in and out. Through the interpreters, they slowly discuss the pain. They negotiate the medications. Both the intern and Jose are frustrated about how the conversation ends. Sometimes during this painstaking dance, another dose is given, and sometimes the 4-hour window simply ends, so Jose receives the dose that he was planned to get anyways. But the standing orders don't change, and the cycle repeats itself on and on. I think this guy's an opiate abuser, blurts the intern when Jose is mentioned on rounds. I like the intern, but I don't like his words. I know my intern colleague is stressed out, overworked, and struggling under newfound responsibilities. He is brand new, juggling 10 medically complex patients. The intern's life consists of 12-hour shifts, 6 days in a row, 80-hour work weeks stacked one onto another for the foreseeable future. Jose has been on our service for a few days now, and my intern friend is frustrated that he isn't getting better faster. He feels that Jose's requests for pain medications are a particular thorn in his side, waking him up on his overnight call and adding an extra task to an already busy day. I think he's faking it, he tells us during rounds. We know he's abusing alcohol. Why should we think he's not abusing opioids too? It's a real concern, states the attending, whose gray hair and old school internal medicine style includes intermittently agreeing and disagreeing with most statements in his general vicinity. Many of these chronic pancreatitis guys do become opiate addicts because they end up on narcotics long term for their pain. But at the same time, we know this is a legitimately painful condition. We have a CT scan showing an actively inflamed pancreas, and he's still vomiting, not able to eat. So if you guys want to give him more narcotics, it's fine with me. This guy is either going to become an addict because of his disease or he's not. A couple of extra doses of Dilaudid aren't going to make a big difference either way. I'd recommend just giving him what he wants and getting on with dealing with his actual medical issues. The intern considers this. I just think it's a bad idea to give a drug-seeking patient more opioids. Later, I asked the intern, what's your concern? You know, opioids are very available on the street. If he only wanted to get high, it wouldn't be hard for him to do so. I know, he tells me, but I'm pretty sure he's drug-seeking, and he's asked so many times, and I've said no every time. Now I just don't want him to win. That statement struck with me. I don't want him to win. Months later, the second patient is an older woman, let's call her Monica, who has an undiagnosed pain syndrome. She lives in a wealthy neighborhood and is surrounded by caring friends and family. I see her at an ambulatory clinic located at Man's Best Hospital, or at least that's what the billboards call it. Reading her chart, I see a set of well-curated notes from her pain specialist team. They clarify in big block letters. Her opioid regimen is admittedly high dose, but it is well deserved and known to the pain team. The message to other doctors is clear. Please do not interfere in our work. Every workup known to Man's Best Hospital has been done to no avail to discover the cause of this 10 out of 10 pain, but a steady regimen of high-dose opioids and ketamine infusions, gabapentin, and acupuncture is helpful in keeping the crippling pain at bay. I run her MME calculator. The result is over 600 units per day, more than 60 times the daily dose that Jose was receiving so many months before. Looking over my shoulder at these numbers, my attending says knowingly, opioids have no ceiling effects. You can just keep going up and up and up. When I meet Monica, she is well-dressed, stately, and white. Her family accompanied her to the clinic. They are also elegantly dressed, well-informed about treatment options, asking good questions. Monica tells me about her pain, how crippling and frightening it is. She tells us how the opioids help keep the clawing sensations at bay, but her mind is focused on finding a diagnosis. Doctor, please help us figure this out. Monica has faith in the system. There's no question that her pain is real, my attending tells me. I just hope we aren't missing something on her scans. Monica was concerned about being dependent on such high-dose opioids, but she feels that the alternative, letting the full pain creep back in, would be far worse. She asked what else can be done with the certainty of a patient who knows that no reasonable option would ever be denied her. These are just two of the countless stories that I have been privileged enough to witness on the white-knuckle adventure of clerkship here. Many of them involve great pain, and I've also seen the damage that opioid addiction can do. Patients who sought out opioids on their own and had their lives rendered completely dependent to them, often hastening on an early death. The same molecule both comforts the sick and dying and kills over 100,000 Americans each year from overdose. And in the midst of these tensions, each physician finds their stance. I remember the surgeons who said, I don't prescribe narcotics even though they cut flesh. The 7 a.m. meeting with bar graphs showing the number of opioid pills dispensed on average by each surgeon, publicly identifying those who gave more. I remember a sign that I saw at a free clinic stating, we do not prescribe narcotics here at Man's Perfectly Average Free Clinic for the Poor. That means no opioids, no benzodiazepines, no stimulants. But I also remember all the times that pain medications were given without a second thought. At the mention of discomfort, the automatic badging into the computer to order up more relief. All of these stories scroll through my mind, and I think about statistics, which are simply the summation of all of these stories and every other story in the state of California added up and compressed into numbers. And I think about how disappointing it is that people living in the whitest parts of our state are 3 times more likely to receive an opioid or a benzodiazepine each year compared to those living in the least white neighborhoods. People in Beverly Hills are 3 times more likely to receive an opioid compared to people in Watts, but I do not believe that they have 3 times more pain. I do not believe that white people have more pain in California, but white pain is far more likely to be alleviated with legal opioids in the state of California. Reading the history of medicine, I learned that these trends are nothing new. Across the years in our society, the pendulum has swung back and forth, giving more and less access to opioids based on the whims of the times, adding barriers and taking them away. But one constant is the steady, greater access to controlled substances legally among the privileged. When I think about the stories of pain, but also of addiction that I have seen and heard from patients sitting in front of me, I don't always know what the right answer is. I don't know how much to push the pendulum towards more relief of pain or away to less risk of addiction. But I do know that the pendulum should not depend on skin color, on income, on zip code, on race, or on how much the patient looks and speaks like the doctor. In the heat of the moment, so much of medical decision-making is intuition, gestalt, vibes. We trust our gut. But at the population level, our vibes end up treating the pain of some and doubting the pain of others. Why do our doubts line up so well with race and money and redlining and toxic pollution and all of the other profound injustices of our city and our society? I ask myself these questions, but I know the answers are not monolithic or easy to find. At the end of the day, it is our privilege and responsibility as clinicians to validate, formalize, and treat the pain of our patients, and it is my hope that as the pendulum continues to swing back and forth, giving more and less access to these medications, it can also swing towards a situation of equity in the validation and treatment of suffering for all patients. Thank you.